Hello, everybody. Welcome to the World Molecular Imaging Society webinar on advances in spectral CT and deep learning in preclinical imaging, given by Dr. Christian Badea. Before we start the seminar, a few announcements. First one, as a reminder, don't forget we have a beautiful webinar on advances in spectral CT and deep learning. We have an upcoming annual meeting in the beautiful city of Prague. Details at the society website, wmis.com. And the abstract deadline is April 17th. Second announcement is that the Optical Surgical Navigation Society, or interest group rather, is sponsoring a symposium with Stanford with this coming Friday. In person and then virtual as well, and details are on the website as well on the bottom. And I can put these links in the chat if it's available for everybody to access. And this webinar is brought to you by the Image Data Science Interest Group. The mission of the interest group is to advance the application of image data science across all research domains of interest to the members of the society. And some topics include advancing quantitative imaging and computational imaging, imaging physics, machine learning, deep learning, and AI in imaging and decision science, integrating image data science with multi-scale information, and developing of computational models of human disease in concert with imaging and data. And lastly, these days, we have a lot of data, and the big data needs are enormous in preclinical and clinical imaging. So one focus is to develop imaging informatics platform to integrate and automate image data science pipelines. And I'll urge you all that are interested in this topics to join the interest group. And with that, one of our upcoming current webinar and future webinars is in this area. And I'm delighted to introduce Dr. Christian Badea. Christian has got his PhD from the University of Patras in Greece in 2001 and joined Duke in 2003. So it sounds like about 20 years he's been at Duke. He's a professor of radiology and biomedical engineering. His lab primarily focuses on developing novel quantitative imaging systems, construction algorithms, and analysis pipelines. And his major expertise is in preclinical imaging, in CT in particular, and developing novel strategies for spectral CT imaging using nanoparticle-based contrast agents for theranostics. He's also engaged in developing new approaches for multidimensional CT image reconstruction to address undersampling cases in cardiac and spectral CT, dual energy and photon counting, using compressed sensing and/or deep learning approaches. I can also mention that Christian is highly involved in the effort within the NCI, the co-clinical imaging program, where his invaluable insight and contribution have helped the group and the network to advance CT applications in preclinical imaging CT. And with that, I'm gonna ask Christian to share his slides, and I'm gonna stop sharing mine.
Thank you, Kush. Let me try to share my slides here. Can you see my slides? Again, thank you to WMIS and as well to the Image Data Science Working Group and to Kuresh for inviting me to present today. This is, you see my slides? You see my slides?
Yes.
Okay, so everything, you can hear me and everything is fine? Yes, I suppose the answer is yes. So the focus today of this talk is on spectral CT, and I'm going to show you some what I call case studies where developing instruments for preclinical spectral CT gave us a lot of challenges and problems to solve. And a very hot topic nowadays is deep learning, machine learning. So I'm going to show you some examples of applications of deep learning and machine learning in preclinical CT. So the focus again is preclinical imaging. I wouldn't be able to talk today without the help of my group here. In particular, I would like to stress, really most of the work here has been done by Dr. Clark and Alex Alfin, Rohan Adkarni as well. I'm very grateful for the collaborations with Dr. Gagada from Texas Children's, who is making some of the nanoparticles that I'm going to present here, as well as the people at Duke that they are so invaluable for us because they make the animal models for cancer, Dr. Yvonne Maury and Dr. Kirsch. So let's jump to a bit of history of CT technology. And I'm not going to go in details, but CT started in the 70s by Hounsfield and with the creation of EMI scanner. Then somehow the evolution for CT involves some, let's call them quantum leaps. So in the 80s, there was an increase in the scanning speed and reconstruction in such a way that almost so the three-dimensional became possible, and you could have a slice in about a second. Another very important quantum leap was the multi-detector row CT and the helical scanning. That was around the 90s, which really enabled a very fast scanning. Also, if we look at fast scanning, really other important applications appeared, such as cardiac CT and perfusion CT, so 3D plus time in the 90s. But really what we are now at the moment of another quantum leap. They call it revolution, not an evolution. And this is the spectral CT. In particular, we'll talk about various ways of performing spectral CT, but nowadays, the hottest topic, let's say in CT technologies, is the photon counting CT. And we talk about 3D tensor for adding more dimension, let's say, to 3D, in this case, spectral dimensions, and also combining that spectral dimension with the time dimension. So really in a simple, in a way, analogy here, you can think about what happens today with what happened with going from black and white TV, if you like, to color TV. So we're getting into spectral CT or color CT, and in this way we can provide additional information in such a way that we can look at the composition of materials. So it's expected to increase the contrast discrimination without, and I want to stress that, without increasing radiation dose. So that being said, let's step back a bit and understand the process here. So if we look at the single energy or conventional CT, how CT is done nowadays in probably 99% of the cases, you have an X-ray source which emits of polychromatic X-ray beam that is attenuated by a patient, and then on the other side you have a detector. It's an energy integrating detector, which we could call like a black and white detector. Then we have a reconstruction, and in the end we end up with a linear attenuation coefficient in each pixel, or if we normalize the water to a Hounsfield unit. For more than 10 years now, we also have dual energy CT. In one implementation, you can have two X-ray sources. Each of these X-ray sources, they will have a different KVP, we call it, in a way, a different spectrum. The beams are different. They get attenuated differently in the body. And then you have two detectors, for example, again, grayscale detectors, black and white. And what we do in this way, we provide two measurements. What I'm plotting here are the linear attenuation coefficients of iodine and gadolinium. And you can see that there is a dependency of the photon energy. And so although these detectors are not spectrally resolving, the fact that we change the spectrum of the X-ray source, we are able to provide some differences between the two measurements. What is more interesting and what is happening nowadays is that we can extend from those two measurements to even more measurements. And this is happening with the use of the photon counting X-ray detectors. Again, in this situation, we have a single X-ray source, still polychromatic X-ray beam, but the detector here acts more or less like a prism, if you like, in an analogy to light, where the white light is separated, let's say, in different colors. In such a way, also the photon counting X-ray resolving detectors are able to provide more measurements corresponding to different energies or different colors along this linear attenuation lines. So in the first two cases, we were talking about using energy integrating detectors, but I mentioned that you can do spectral CT, and in general, people are referring to spectral CT both using dual energy CT with energy integrating detector, as well as multi-energy CT based on photon counting, as I'm showing here. Okay, so again, if you look in the clinic and you look at dual energy CT with energy integrating detectors, you find different incarnations or implementations from different manufacturers. You have the dual source, dual detector technology, let's say, and system from Siemens. Again, these are two imaging chains that they are orthogonal. This has the advantage that you can scan faster so that you can do cardiac studies. Now, another implementation is the one provided by GE, where you have a single X-ray source and a single detector, but what happens is that the X-ray source is switching the spectrum from one projection to another. And then you have the implementation by Philips, where you have an X-ray source, but you have a detector that has two layers. They are still energy integrating, but having two layers allows to separate in two energies. Now, what happens is once the system acquired these two images, let's say at 80 and 120 kVb, which they have small differences in contrast, then there is software and algorithms that they convert these two images in other images. For example, the iodine maps, which iodine is the contrast materials for contrast agents, which is overlaid on a virtual non-contrast image, or a series of virtual monochromatic images, which they can range from low KEVs to high KEVs. And at low KEVs, for example, you can have a good contrast. At high KEVs, you can have suppression of some of the artifacts. So these are very useful. Now, I want to take you step by step and try to make you understand what is the process, but in the context of preclinical imaging. I'm showing here an image of a mouse. And this image shows the anatomy, let's say, in corneal cut here. And you notice here that there are some enhancements. The brightest part in this image, what I can tell you is that we injected two contrast agents. One was based on iodine, and one was based on gold. Now, you cannot tell by just looking at this single energy or conventional micro-CT image here, where was one contrast versus the other. By the way, this mouse also has a large tumor here on the leg. So again, if we look at the mechanism in X-ray, we talk about the Beer's law. And what happens is that you have an intensity of the X-ray beam and it gets attenuated according to this equation here. What is important is that in this equation, you have the linear attenuation coefficients, this mu, which is function of energy and the thickness. Now, again, with single energy CT, we won't be able to discriminate all those probes inside. So it's ambiguous. Now, if we take two measurements with different kVp spectra by changing, in a way, the X-ray source, you notice here that the contrast has slightly changed. As we went to lower kVps, the spleen here became brighter. Okay, so again, if we, knowing that we have two contrast agents, I mentioned iodine-based and gold-based. If we want to understand what happens, let's look at their linear attenuation, how this depends with the energy. So you can see here for each material, for example, for gold, first of all, a discontinuity here around 80 is called a KH. Iodine is not that attenuating as gold, and it has another KH here around 30. Now, suppose I will do two measurements. I mark this by this rectangle, let's say, on the plot here. And if I would measure the difference between the red line and the green line, I notice that there will be not the same difference. There will be slightly, differences between the two measurements. And this will help me separate between the two contrasts using the energy integrating detectors. Okay, so mathematically, in a very simple way, what happens is that I have to use an algorithm to look at every voxel and try to understand how much of gold and how much of the iodine is mixed in, let's say, blood there. So for that, I will solve two equations of two unknowns, and the equations are here. the equations show some the E factors here, which are the enhancement for iodine and gold at energy 1 and 2. Those, they will be provided by scanning vials with known concentrations in such a way that I can derive, for example, A2 per milligram per ml for each of the two materials. And then we have the unknowns, which are the concentration of iodine and gold, as well as the measurements that I will get in the two sets, the CT number at energy 1 or Hounsfield units at energy 1 and CT number at energy 2. So I can then solve this equation where I take the concentration, I use an inverse of the, or so the inverse, let's say, of the sensitivity matrix, and then I could get the concentration in each voxels. So this is what happens. You have the two images, 80 and 40, that we have acquired and reconstructed. Then they go through this algorithm, and then for every pixels, I'm able to color here in red, for example, the iodine map, and in green, I can use to create a map for the gold concentrations, and I can overlay them. Now, this is nice because I can see that the vasculature is in red, and the iodinated contrast agents, it's where it's red. I also have two vials here, one with iodine just to make sure that everything is fine, and this the gold vial. You also notice that the gold nanoparticles, they have accumulated in the spleen and the liver. But the other observation you can make is that, well, what about the bone? The bone looks green too. What is bone, and what is bone being calcium in this case? And what is gold? So yes, that is absolutely true, because I only had two equations and two unknowns, and gold and calcium, they became clustered together, because if I would consider calcium, it would be another unknowns that I will have to solve for. So that would require probably more measurements than two. Okay, so because the audience here is the molecular imaging researchers, I just want to mention a bit something about the contrast agents that we use for CT, the preclinical CT here. First of all, we have the low molecular weight contrast agents, which are used in the clinic, and sometimes we use them also in mice. And as I mentioned, the contrast used for CT, the material, the high Z material is iodine. In some cases where patients, they could have some reaction to iodine and so on, it is possible, and we use clinical also the MR contrast agent, which contains gadolinium, but which also is a high Z element. Now, the nanoparticles are totally different. First of all, they have a size that is, let's say, around 100 nanometers. And I'm showing here two examples. One is the gold nanoparticle, and the other one is an iodinated liposome. Now, the liposomes are very interesting because we are already using liposomes for therapies. For example, Doxil is it's a liposome that is used for chemotherapy. Inside of the liposome, you have doxorubicin, which is a chemo drug used for cancer treatment. In essence, these liposomes they have a lipid bilayer, they have pegylations on. Now, for CT, to make them as a contrast agent, they are containing, instead of the drug here that is used for chemo, we use ihexyl, which is exactly the clinical contrast agents that contain iodine. The gold nanoparticles are chunks of metals. They have some protective layers, but essentially they are not vesicles like this. Now, what happens when we use this type of nanoparticles in preclinical studies, for example, to study cancer? So let's suppose we have a mouse and we have inoculated some tumor here, let's say sarcoma in the leg. And then we inject this iodinated liposomes, by the way, made by Dr. Kagada. And immediately after injection, we can clearly nicely see this vascular imaging. If we want to look at the vasculature in the tumor, then we can even derive a biomarker such as fractional blood volume, for example. So this is immediately after injection. The beauty of these nanoparticles is that they have a large size and they are pegylations, and they have a long residence time. The half-life time is about 40 hours. So it allows you to do a lot of imaging if you like. Now, a couple of days later, if we image from 3 days to 7 days, the contrast is going to be cleared from the blood. And what happens is that, again, because of their size, it's going to be accumulated in the liver and spleen, but also because of enhanced permeability and retention, is going to be accumulating in the tumor. Enhanced permeability and retention, again, I'm sure you know, It's caused by the leakiness of the vasculature in the tumors. And these macromolecules, let's say, they circulate and they leak out from the vasculature into the tumor because of that EPR effect. This is interesting because if I do a CT at this time point, I can understand something about the permeability of the vasculature. And this is very good because, again, we are interested, for example, in drug delivery. And as I mentioned, these iodinated liposomes in a way are surrogates for liposomes of drugs. So we can use CT in this way to study drug delivery. I'm going to give you an example where we actually have used the 2 nanoparticles in a study of cancer. And this was, I think, interesting from multiple points of view. First of all, it was a theranostic study. So gold nanoparticles, apart from the fact that they can be used for imaging, they have a lot of other qualities. One of them is that they can augment radiation therapy. So in this study in particular, we have injected mice with sarcoma tumors with this gold nanoparticles. And then we have let them accumulate through EPR, so passive accumulation in tumors. And then we have, I'm sorry, I'm taking back. Actually, these gold nanoparticles were even more interesting. They were RGD targeted. So there was both a passive and active, let's say, targeting of the tumor. But afterwards, we perform radiation therapy with 20 grays. And the assumption here was that because of the augmentation of radiation therapy provided by these gold nanoparticles, we are going to create this vascular disruption. We are going to make the leakiness even more enhanced, let's say, in tumor, in such a way that if we come with another particle, such as this liposomes, we can deliver more of them in tumors. Now, this was done first as an imaging study where this iodinated liposomes were used to optimize and to maximize, in a way, the delivery. And the fact that we were able to separate between the 2 nanoparticles based on dual energy CT, in this case, energy integrating CT, allowed us to do this optimization study. But once we did that, then obviously we have replaced the iodinated liposomes with the doxil, which is really the drug-containing doxorubicin. In such a way, this is now a combination therapy study where we have combined augmented gold augmented RT plus doxil. And you can look here at the tumor doubling time, and you can see that this is the longest for the combination therapy, which involves both augmented RT by gold and doxil compared to single therapy alone, like obviously no treatment, doxil, RT alone, or RT plus doxil. Again, this is one of the possible way that you can use spectral CT for, and I believe there is a lot of future for theranostic studies like this involving nanoparticles, like in this case, in studying cancer combination therapies, but also having CT to help for that. I want to step back and now talk about actually photon counting CT, because what you've seen before was dual energy using energy integrating detectors. But what are the differences between the photon counting and the energy integrating detectors? So if you look at the EID, or energy integrating detectors, they are, in a way, we call them that they work with indirect conversions. So in essence, they have a scintillator, which is gallium oxysulfide, for example, gadolinium oxysulfide, I'm sorry. And then what happens is the X-ray photons that they convert it to light, and then you have a photodiode on the other side, which transforms that light into an electrical circuit, into an electrical signal in an image. Now, on the photon counting side, or PCD detectors, we don't have this indirect conversion. It's a direct conversion. You have a semiconductor, which is typically cadmium telluride, or it could be gallium arsenide or cesium iodide, for example. No, gallium arsenide or silicon, I'm sorry. And then what happens is the X-rays, they are passing through the semiconductor. You have some circuit here, electrical circuit, and in the end, you create an image. But really, this is not all. If you look at this animation here, photon counting, as it says, it counts photons, and it counts them, and it bins them according to their energies. Think about that there are, in a way, some thresholds into the detector, and if a photon X-ray photon comes, it's looking at the energy of that X-ray photon, is comparing with some thresholds energy threshold and saying, hey, if it's higher than a threshold, then I'm going to put it in a certain energy bin. If it's higher than another threshold, another energy bin, and so on. In a way, if we come back to the linear attenuation plots that we have here, for example, in our detectors, we have 4 thresholds that we can set, and we'll end up with 4 measurements like that. So from dual energy, we can now go to 4 energy CT in this way. What about the compositions? Well, you've seen before how we did it in a post-reconstruction method for the dual energy. It's about the same here, except that now we can add more unknowns. So we have the 2 contrast agents, the iodine and the gold, but we also have 2 other terms here which you could add because we have 4 measurements, and these are what we call physics bases for the compositions, and these are the Compton effect and the photoelectric effect, and both they have some dependency with the energy. So we are measuring, let's say, and creating the composition maps for the photoelectric effect and Compton scattering and iodine and gold. So again, these are the KH materials. We have this linear attenuation. And in the end, if we look back at our mouse, which was injected both with iodinated and gold nanoparticles, the fact that we also have P and CS, the photoelectric and Compton scattering, allows us now to separate nicely the bone from the rest. So you can see here in green, you can see the gold accumulation, in red, the vasculature, and in the background, you can see the body, the soft tissue. So this is much cleaner as an image of what I showed you before. And this is also because we can solve for 4 unknowns using the 4 measurements. Over the year, we have built a number of prototypes for spectral preclinical CT. So the first one was a dual source, dual energy CT, similar to what Siemens has in the clinic, in the sense that we did have X-ray clinical tubes here. We had 2 high resolution detectors, that they're energy integrated detectors, and we have the mouse in the middle here. More recently, we have developed this dual source hybrid CT, which we use for in vivo imaging. It's called hybrid because we have one of the imaging chain is using a photon counting detector, and another one it's using an energy integrating detector. And I'm going to show you examples of how it's beneficial actually to keep one of the energy integrating detector as well for some imaging applications. Finally, we have another system that it's using a higher resolution photon counting detector, and we use that for ex vivo scans. Okay. That being said, my group is doing research somewhere at the border of engineering and physics, and also looking for applications and working with people that they develop nanoparticles, and working with clinicians to find significant applications, what we're doing. But I want to give you an idea of the type of challenges that we faced, perhaps at the engineering level, when we built some of these prototypes. We were working with the X-ray, which was one of the companies in the US that started the development of photon counting detectors. And one of the early prototypes was really a tiny stamp of a prototype of a photon counting detector. So it was only 16 by 16 pixels, about 8mm by 8mm in size. And so that was very small, and you had to translate them. So we had to do this translate rotate geometry for the acquisition. And there were 4 thresholds, but the quality of the images that we were getting, you can't comment here, because apart from being very small, almost stamp-like, a lot of the pixels on these detectors, they were dead pixels, as you can see here. So we went through a lot of trying to solve for these problems was not easy, to say that. First of all, the tiny stamps projections, they had to be stitched together, and then we had all kind of corrections that we had to do for the bad or dark pixels. You can see here some interpolation that we managed to do, and then normalization and log correction with the arrow images. We started looking like a normal image, as you can see here. But that was not really the end of it, because even if we corrected for the dead pixels, there were still some pixels which they had, let's say, non-linear response. When you look at these projections, which are now stacked into a sinogram direction, into angle directions to create these sinograms, you can see these vertical lines where those pixels are not responding. They're not dead completely, but they're not responding in a normal way, like in a linear way, like the other ones. So if you have these columns here, which in the sinogram, then when you try to do an image reconstruction, you end up with what they call ring artifacts, which is a typical type of artifacts for third generation CT scanners. I'm going to show you how we dealt with this problems, but before, I just want to step back a bit and actually ask you if you have this type of problems, because you have them every day. So I showed you already all type of sensor measurements and problems that we have, that detector, which had bad pixels and so on, in such a way that we ended up with corrupt signals. Sometimes we want to segment data, and how do we do that? Well, sometimes it's a lot of manual work for that. Other times you have computationally expensive algorithms. All this iterative reconstruction that you are doing is very expensive. Sometimes you just miss data, for example, because the detector is not large enough. Well, for all these situations, we want to find some solutions. And over the years, we have developed algorithms and ways to deal with that. But the last couple of years, we also understood that there are other ways with other approaches, which most of the time are data-driven, that can be used for solving this problem. So as we know, machine learning is maybe larger than deep learning, and somehow included in the artificial intelligence. And really, it's changing the world already. So it was almost straightforward that we had to try some of these approaches to solve some of our problems. And I'm going to share with you just a number of applications or challenges, let's say, and solutions that we provided using deep learning. So in a very simplistic way, let's say we have very noisy images, and this is very common for photon counting CT, because you have a budget of X-ray photons, and you actually bin this in different energy bins. So you end up with energy bins that they have very few photons, especially the high energy ones. And that results in a lot of noise. So we end up with having images that we try to reconstruct, and they are very noisy. But you can also, maybe you increase the dose sometimes, or use smarter algorithms like iterative reconstruction, and in such a way that we can provide what we call training labels for our ML algorithm or deep learning algorithms, that they have less noise. So again, the deep learning algorithm here, in a way, we can think about it as a gray box. Once we have the supervised learning approach that we take here, if we have training examples and training labels, then the algorithm learns by looking at the data and trying to minimize a cost function. There is an optimization algorithm involved so that it learns to denoise these images. And then at the level of inference, after learning, we can come with other images and we learn to denoise them. The advantage would be that perhaps sometimes the denoising would be much faster than with the traditional algorithms like iterative reconstruction. Okay, so let's go back to our case where we were thinking about how can we correct for some of these ring artifacts. Again, sinograms, bad pixels here, vertical lines, and you do the reconstruction, you end up with this ring artifacts. Well, how about deep learning? So what we ended up doing was to use a UNet. A UNet was proposed initially for segmentation. Is probably one of the most commonly used structure for deep learning. We also created sets, and the trick here was that we created sets that they were simulated. We took energy integrated data, which we altered to match the type of artifacts that we have into the sinograms that we get from the photon counting. So we created this match labels that they were the clean sinograms, while the input sinograms, they were noisy and they had these vertical lines, let's say. Obviously, this was done in a random way, so we create a lot of projections, a lot of sets like this. Then we went through a process in which we scrambled this sinogram along the angle dimension. We also removed the low frequencies, which we added back here. But in the end, we let the network deals with, let's say, the high frequency artifacts in these images to learn to remove them. And they work pretty well. because if you look at these images, you see the 4 energy images corresponding in this case to 20, 26, 34, 50, and 60 keV. And if you focus here, you can see in each of these no corrected images, you can see the ring. But after the CNN, and also confirmed by the subtraction of the CNN versus the no correction, you can see in the residual images that we have removed the ring artifact. So in an example of the tumor imaging, this was again a mouse which had a sarcoma here, and it was injected with some liposome to gadolinium. And these were actually spectral decomposed images. I'm going to show you some other things about spectral decomposition. But again, if you look at the images which were not corrected and compare it with the one corrected, you can see clearly a removal of those ring artifacts. The improvement was also confirmed by other metrics like the similarity index here. Okay. Again, what about other applications? Work being done here by Matt Holbrook, who now works for Siemens, and Diane Clark. And this application now refers to increasing the resolution. Now, I want to just say here that this is something that we call pan sharpening. And the idea is not coming from the CT world, it's coming from satellite imaging. So in satellite imaging, you have some cameras, which they are very high resolution, but they are black and white. And you have another camera, which is color camera, but it's of lower resolution. And the goal of pan sharpening is to get the best of the two. In other words, you want to get high spatial resolution of the images for mapping and so on, but also colored images. So it's somehow you take the high resolution from black and white and the color from the color low resolution images. So in our case, when we were getting these prototypes from the X-ray, the pixel size on this detector is about 1 millimeter. Now, for you, some of you that you do small animal imaging, you understand that 1 millimeter is very poor resolution for micro CT. But we did have energy integrating detectors, which they are let's call them the black and white ones, which they had 75 microns pixel size. So we thought about how can we now apply the idea of pan sharpening of, in a way, combining the information of the two detectors. Why is that important? For example, we are looking at the atherosclerosis in mouse model, and would like to be able to understand atherosclerotic plaque composition. But you need for that, obviously, very high resolution, but you also need the color information. And this would be the low resolution energy beams image coming from the photon counting, and this would be the high resolution black and white image. The goal would be to get this high resolution decompositions that we can use maybe to understand the atherosclerotic plaque composition. So again, we looked for a deep learning solution. So in this case, it was not a UNet. It was a structure that combined, let's say, a deep network with a shallow network. In the deep network here, we had some inception modules, 2 inception modules that they combine in a parallel way, different filters of different sizes. And on the shallow network, again, idea taken from super resolution papers and so on. Another shallow network here that improves the resolution aspects of this deep learning structure here. What about training? So again, we use the energy integrated data acquired at multi KVPs. So in a way with different contrast, and we used it in the following way. We always fed 2 images to the network. One was a high resolution, let's say black and white image, and another one which had a different contrast was a low resolution, and again, a different contrast image. The output would be the contrast of the low resolution image, but with the high resolution of the black and white image. How did we create the low resolution images with different, they had different contrast in the other image? Was just by applying a Gaussian blurring there, Gaussian filtering that matched the resolution of the PCD data. So we trained this, and as you can see here, this was the phantom that we had some high frequency structure here, and it had some iodine and gold vials. So when you look at this image, you appreciate that it's kind of low resolution. When we went through post pan sharpening here for the network, you also kept the colors, but we also enhanced in a way the resolution of those. And this is confirmed by the modulation transfer function in this image which now is at the level of the energy integrating data. Great. So we dealt so far with correcting some of the artifacts, and we also looked at increasing resolution. What about denoising? Well, this is work again done by Diane Clark, and you know, we were the first actually to do cardiac micro CT, cardiac micro CT in a mouse, and we evolved over the years, reduced the dose and so on. But you can still appreciate that, you know, the cardiac imaging. You know, when you try to reconstruct the cardiac motion and so on, and try to minimize the dose, you end up with quite some noisy images, especially if you use filtered back projection or the traditional analytical reconstruction algorithms. So the way we do it right now is obviously we do iterative reconstruction and we get a factor of 2 perhaps in noise reduction if you do iterative reconstruction as we show here. The problem with that is that this process, which involves, by the way, 10 time points, 10 cardiac phases that we try to reconstruct in parallel, each one a 3-dimensional volume. Or if we add also the energies, then it will be 40 3-dimensional volumes like that, because you have 4 energies as well. Well, the algorithms take a long time. And we have developed over the year this multi-channel reconstruction toolkit that is able to deal with time and energy, and is running on the GPUs, is optimized for that, and is using sophisticated image reconstruction based on split Bregman, all type of regularization models such as rank reduction and gradient sparsity and so on, based on information about prior information, such for example, you know, the CT images, for example, are piecewise constant and so on. But all this process takes quite a bit of time. So we were thinking maybe we can use regularization that is a deep learning approach. Or maybe we can use a single step denoising, let's say, provided by the deep learning instead of the iterative reconstruction, but perhaps it could replace the iterative reconstruction. To look at this problem, give you some example here with data acquired on our DECTRIS detector. This is a retrospective gating acquisition where you acquire 9,000 projections. The images are only with 10 milliseconds exposure, so they are very short in time, because you want to, the heart is beating about 10 times, or I'm sorry, about, yeah, it's about 500 or 500 beats per minute, let's say. So the dose you want to keep very low. I mean, and we would like to get, you know, images which are denoised. Iterative reconstruction in the middle can be used perhaps as a label. And to create more sets that they look even more noisy, we have used undersampling. So we have did the equivalent of a quarter dose of these images. And you can appreciate here how very noisy those images are. I do not have time here to go through the network that we have used here, just to say that this was using 4-dimensional convolution layers, that they were developed by Diane Clark, and there were multiple 3D convolutions with cyclic delays that they account for the time phases in this way. So, and it was pretty intensive in terms of computation to be able to solve this. That's why you have this asymmetric nature that we have for the UNet here. Okay, in terms of results, on the top here, you can see the input of the PCD data corresponding to the 4 energies. You can appreciate how noisy the last energy bin is, and the result after passing through this 4-dimensional CNN. Just to say that, you know, we are not doing this just for the sake of developing imaging, but we are applying it, for example, to look at, again, mice that they are a model for atherosclerosis, in this case, ApoE knockout mice, that they have some atherosclerotic plaque here. What you see here in red is, well, this image, first of all, is the material decomposition image, which keeps the iodine, in this case, iodine was liposomal iodine that was injected as a contrast agent, and is able to separate from the calcium in the plaques, let's say, which are shown here in green. Okay, so the final case study that I'm going to show you is regarding material decomposition. And the problem with PCDs is that although they are so revolutionary, I would say, they are not perfect. So there are still a lot of issues in terms of the physics and effects that they happen in this semiconductors. Let's say we talk about charge sharing, we talk about K-escape fluorescence and pulse pileup and so on. All these effects, which I will not be able to go into details, they create spectral distortion. To understand what it means is, let's say I would have a photon counting detector and I will try to use a threshold that is changing every keV, and I'll try to look at the spectrum of 80 kVp that comes from our X-ray source. An undistorted spectrum will look like this red line. But if I would try to measure it with the photon counting detector, then I will get something like the blue line here. And all this shifting of the spectrum is caused by the spectral distortions. So for a number of years, people are trying to find solutions to the spectral distortions. And I'm going to show you here a possible solution, which is based on deep learning and, again, a supervised learning approach, where the fact that we have developed a system which is a hybrid system is actually something helpful for us. So remember that we have an energy integrating detector, so we can acquire multiple sets, even at high dose, because this will be in dead mice and so on. And we are going to use different KVPs in such a way that we can get, for example, 3 multi-KVP images. And the energy integrated detectors, they do not have the spectral distortion of the photon counting detectors. So in this way, with Rohan Nadkarni, we were able to create data that we can use for spectral decomposition, perhaps improvements in the spectral decomposition that we can achieve with the PCD. Again, I said we have used a number of mice that have been injected with liposomes of iodine. By the way, these mice, we also have a range of vials here that we use for calibration measurements and so on. But we show here the photon counting data reconstructed with filtered back projection. You can appreciate that it's noisier at 60 keV here. But if we do iterative reconstruction, the images look better if we perform material decomposition and we separate here the iodine, the quantum scattering image, and the photoelectric effect. Just to give you an idea, the photoelectric effect, for example, the bone would be more likely to be in a photoelectric effect. We have a vial here of calcium that appears to be green, but you also notice a lot of background of that green where it shouldn't be. We know that because if you do multi-energy integrated detector sets like this, 3 kVps here, so using the normal detector and using a higher dose, again, these are dead mice and we don't care too much about the dose since we are trying to create these training labels, then the energy decomposition doesn't have the spectral distortions. It looks much cleaner than the PCD decomposition here. You can appreciate, for example, the P component here, which is the green one, which doesn't have that background like we have on top. And also there are other effects in the iodine map, if you notice, in the PCD, like those Ream effects and so on. So in essence, we took the multi-energy integrated data, which was used for decompositions as labels, and then we tried different approaches. We have tried to train with filtered back projection photon counting data and with iterative reconstruction of the photon counting data, as well as decomposed data from photon counting, using, again, a unit. Is this working? Well, let me show you example then. After we trained, we used the network to decompose a live mouse. This mouse had a sarcoma tumor in the leg here, and we injected iodinated liposomes. We did a composition in the iodine maps. What is important here in the PCD decomposition, again, these were not corrected. You can see there is a lot of crosstalk, if you like, between iodine and calcium here, the vials, right? So you get this green where it shouldn't be actually calcium there because it's just the iodine vial. In the end, if you use the decomposition provided by our network, that crosstalk is removed. And the image here shows the accumulation of iodine as it should be in the tumor. We also have, by the way, 2 vials here that we keep for calibration and evaluation as well. So I think there is a clear difference between the 2 images, and after the spectral decomposition by the CNN, the bottom image looks much better. Okay, so I've shown you a lot of case studies, let's say, for application for deep learning, but in the end, we developed this photon counting CT because we want to do better imaging and better science that has some significance, for example, in cancer studies. And I'm going to give you an example of how we applied photon counting CT with all these corrections. For example, to understand if we can use radiomic analysis to separate between tumors, between mice that they had two types of tumors. So first of all, we use a high mutational load transplant soft tissue sarcoma model, again, provided by Dr. Maury. And this was initiated in mice, in RAG2 knockout mice. These are mice that they are immune deficient, let's say. They do not have mature T and B cells, while the controls here, they have mature T and B cells. So we have created now two groups by engineering the mice in such a way that once they have normal tumor-infiltrating lymphocytes and the other ones, they don't. And the question that we are trying to answer is, can I use photon counting CT plus radiomics to understand the differences just based on the images between the two groups? Okay, so the experiment, we started by injecting liposome to iodine in these mice, and also we performed 20 grays of radiation. Then what we did, we imaged the mice both with energy integrating CT, day 5 here, so a couple of days later, so we allow for passive accumulation of the liposomes in tumors. So we image with energy integrating detectors and photon counting detectors. We use the PCD data to provide spectral decompositions. We segmented the tumors, and then we proceeded to do a radiomic analysis and try to see if we can separate between the two groups. How do the images look like? Well, the PCD images, they look like this. So we have 4 energies, and then we have another energy integrated image, right? So from the PCD data, we have created spectral maps like this. You can see that there is some accumulation in red here in the tumor. Always keep some vials of known concentration in such a way that we know for sure that we are doing well, or, you know, if we have to make sure that, you know, our decomposition are right and so on. So let's look at the results. So first of all, we look at what we call semantic features, if you like, radiomic features. And this involved what you can understand, like the tumor volume or how much the iodine accumulated in the tumor to the EPR. So the only measure here or feature that was significantly different between the two groups was the iodine mean concentration. And you can see that the controlled groups, let's say the more like the normal mice, they accumulated more, they had more leaky vasculature than the mice that they have the immune deficient, let's say, like they didn't have BNT mature cells. But this is not enough, because then we looked also at, let's say, the agnostic radiomic analysis, where you get all these hundreds of features that you can compute looking at texture and shape and morphology and so on. And once we have these hundreds of features computed, as I said, for PCD data, for EID data, and for the decompositions, then we train a classifier, obviously, and we looked at how well we can separate between the two groups. And what we got here, we showed that, you know, in terms of when we did all the ROC analysis and so on, we ended up with the best performance being provided by the PCD data compared to the EID, so best accuracy, area under the curve, and precision recall. And PCD alone was even better than material maps. This is not surprising, because material maps are derived from the PCD data. And in a way, you know, when you try to inverse, solve like an inverse problem, in a way, you always have issues of noise and so on, or inaccuracies that could be added by material decomposition. So PCD was, more importantly, it was better than the EID in separating between these two groups. And I think this is important because we show here in this application how you can combine PCT, which is supposed to, photon counting CT, which is supposed to be a more quantitative imaging method. So it will have implication in making CT even more quantitative than it is now, and more reliable, let's say, with some machine learning, which is the radiomic analysis that we are doing here, to be able to extract maybe some extra information that will separate different tumors of different genotypes, for example, based on their imaging appearance. I'm almost at the end here, and I would like to say that whatever we do here is not isolated. In a way, there is already a clinical equivalent of what we're doing. So Siemens got an approval for the photon counting CT scanner in 2021. And at Duke, we already have the Siemens Neatom Alpha, which is a dual source photon counting scanner. Now, what I did last year was to take some of our mice that obviously they were dead when we went to the clinic, but we did some imaging, and these mice, they were injected before being killed with, again, iodine and gold and so on nanoparticles. You can do two types of scans. One, which is a very high resolution scan on this photon counting clinical scanner. And these were 150 microns images. I want to say that this is almost at the resolution that you do micro CT. So I haven't talked much about the major advantage that photon counting brings, which is enhancing the resolution. This is what we see now in the clinic. A lot of papers appearing and showing how much better the resolution is in photon counting versus conventional CT. The other way was to look at the material decomposition. In the implementation that exists today, you can only use 2 of the thresholds, but we hope that this will change to more thresholds in the future. So you can see now in these 2 mice, which were injected with iodine and gold, that you can get differences. So we was able to resolve them, to resolve the 2 contrast agents. Which brings me to this idea of co-clinical. As Kuresh has mentioned, we are part of the CIRP network, which is the co-clinical imaging and research programs. In essence, co-clinical trials are these trials for cancer, in our case, where you are trying to replicate the preclinical level, whatever happens at the clinical level. So you have a preclinical arm for the clinical trial, but that has to also involve imaging. So we also try to do this parallel with whatever happens in terms of imaging at the clinical level to mimic or to provide a similar imaging at the preclinical level. And this is very powerful because we have a system in the clinic that we also have our system here. And if we talk about all these algorithms that I mentioned before, the problems many times are the same. Photon counting on the clinical side is as noisy and the noise challenge is the same. So some of the algorithms that we are developing here could be translational. But also, if we talk about things like translating maybe future contrast agent, I mentioned about this liposomes, which they have iodinated content here. Having this way of going from the clinical and preclinical, and maybe both ways, let's say, will allow development and testing of these nanoparticles, and maybe combination studies and so on, as I showed you, theranostic studies. I want to mention that there is a preclinical scanner, color spectral scanner made by Mars in New Zealand. So that being said, this is my last slide. I just want to, I hope I gave you reasons to believe that spectral CT is in a way the next quantum leap in the development of CT imaging. I think preclinical spectral CT will serve as a testing ground for not only new contrast agents and therapies, but also new algorithms, let's say, for dealing with problems that we face now on the clinical side. And I think it's very interesting, as I mentioned, because if we combine them with development of novel contrast agents or nanoparticles used for theranostics to test maybe combination therapies, it can really help for these high Z-based nanoparticles. I also showed you examples of how deep learning could serve some of the challenges that we faced at the engineering level when we implemented this, or we tried to improve imaging. I showed you how we can decrease noise and increase resolution, maybe even replace it with deep reconstruction or improve spectral decomposition. It's worth mentioning, however, that some of these, actually all that I showed you, they were based on supervised learning. And that means that they are powerful, but require fixed protocols and, in a way, reproducible image quality. And the future, and also what we are trying to do now, is to make this approaches more generalizable. And this could come through semi-supervised or unsupervised approaches. And I think there is a lot of work going that way. With this, I would like to thank you, and I will be very happy to answer questions.
And thank you, Christian. Beautiful talk and really wonderful, impactful work. I think we are on the hour, so I want to ask everybody that has questions and can stay behind to join the social lounge, and then Christian will stay with us for any Q&A that we have. Thank you.